Good morning. Hello, everyone. Thank you, General Malcolm and Mr. Nick Booth for the introduction. We're very pleased and honored to have this opportunity to speak with you today to share about our program of research as well as recent findings from our cancer incidence study. So as mentioned, my name's Andrea Jones. Myself and the study team members have no relationships with commercial interests and no potential for conflicts of interest for disclosure. Myself and all study team members all work for one of either the Department of National Defence or Veterans Affairs Canada. And no bias mitigation has been undertaken. I'd like to acknowledge both Veterans Affairs Canada and the Department of National Defence for their support in this program of research, as well as Statistics Canada for their support and services. I'd also like to thank the Surgeon General and True Patriot Love Foundation for this opportunity, and CIMVHR for their support in developing this presentation. The Canadian Forces Cancer and Mortality Study, which we often refer to as CFCAMS for short, a number of people have contributed to this research program over the years. The current study team includes myself and Dr. Amy Hall at Veterans Affairs Canada, and Daniel Cousineau-Short and Chrissy Galanakis at the Department of National Defence. The cancer incidence study, which I'll present findings from today, also included Dr. Deborah Weiss from DND. So the learning objectives are threefold. First, by sharing about our own program of research, we hope to convey the concept and utility of cohort-based data linkage for military and veteran health research. Second, we'll describe the crude rates of primary incident cancers in male and female personnel and veterans. Then lastly, we'll compare these rates to the Canadian general population. For the outline, we'll have a brief introduction, followed by a high-level overview of the CFCAMS program of research. Then we'll take a more narrow focus on the cancer incidence branch of this research program, including findings from our initial study, which we presented at CIMVHR Forum last year, as well as a discussion of the implications and next steps. So, as I'm sure everyone knows, cancer is a leading cause of death in Canada, and the same is true for Canadian veterans. Cancer is also extremely prevalent. Approximately 40% of us will be diagnosed with cancer at least once in our lifetime. Further, cancer is to some extent preventable. According to the Canadian Cancer Society, approximately 4 in 10 cancer cases can be prevented through healthy living, as well as policies that promote a healthy lifestyle and reduced exposure to environmental risk factors and other agents. But you might be wondering, why study cancer in a military and veteran population specifically? Well, military personnel and veterans may potentially have unique cancer risk profiles that differ from their general population counterparts. This could occur for a number of reasons, including differences in both protective and risk factors. Potential examples include differences in occupational exposures, differences in health behavior patterns, as well as differences in use of preventative health services. In regards to occupational exposures, some exposures may be unique to military service or more common to military service, whereas other exposures that may be encountered during service may also be encountered during civilian workplaces. However, military service in itself is unique, with unique demands. Thus, patterns of exposure, including frequency and intensity, may vary between civilian and military contexts. Ultimately, with research of this nature, we help to produce evidence that can be used to inform health promotion and benefits programs specifically tailored to the needs of military personnel and veterans. So, as mentioned earlier, CFCAMS stands for the Canadian Forces Cancer and Mortality Study. This is a well-established, cross-departmental research collaboration between Veterans Affairs Canada and the Department of National Defence. We also receive support from Statistics Canada. This includes a large, robust, population-based cohort of everyone who has served in the Canadian Armed Forces since the mid-1970s up to recent years. It was originally designed to capture incident cancer and mortality events. However, it's since been expanded to include other outcomes, such as injury in serving personnel. Under the area of mortality, CFCAMS also serves as the basis for the Veteran Suicide Mortality Study, through which Veterans Affairs Canada observes trends in veteran suicide mortality over time. The general purpose of the program is twofold. The first is to examine key health outcomes and to compare these to the general population. And the second is to examine these health outcomes by military characteristics, including occupation, service rank, and history of deployment. So, a very integral component of this research program is its database. As you'll see at the top of this slide, a cohort data file is compiled by the Department of National Defense using its internal administrative data holdings. This is largely the human resources system data and the digitized pay system. This cohort data file includes variables describing characteristics of service, such as enrollment date and release, rank, occupation, and deployment information. Once compiled, the data file is transferred to Statistics Canada through a secure e-file transfer system, where it is de-identified and linked to national-level health registries at the individual level. This includes the Canadian Vital Statistics Database, which includes mortality outcomes, as well as the Canadian Cancer Registry. This summarizes the 15-year timeline of the CFCAMS program of research. The first linkage was conducted in 2010, and the most recent is currently underway. With each additional linkage, additional personnel are added to the cohort, and health outcomes are updated to include additional years of follow-up. The cancer incidence study I'll be presenting on today used the 2021 linkage. The upcoming data linkage currently underway will include an expanded number of health measures through linkages to additional data sets available in Statistics Canada internal data holdings. This includes data describing hospital and ambulatory events, as well as maternity and mental health care and services. Here we highlight some key features of the CFCAMS program of research. First, I'd like to note that throughout the presentation, I frequently will use the terms males and females. And this is because our data holdings contain information on sex, but not other aspects of sex and gender, such as gender identity. As the CFCAMS program of research is population-based, we're effectively able to compare everyone who has served in the Canadian Armed Forces since the mid-1970s to the Canadian general population over a 42-year time period. The long follow-up period allows us to examine health outcomes with long latency periods that may not occur until after service, as is often the case with cancer. The large cohort also allows us to examine outcomes in more detail, such as cause-specific mortality or specific cancer types, including those that are more rare. The large cohort also allows us to examine health outcomes by service characteristics for males and females separately. This latter point is quite important, as females are often underrepresented and sometimes even excluded in the military health literature, including studies focused on cancer incidence. The data linkage methodology leverages existing high-quality national-level health registries that are already routinely updated and maintained. This, combined with the high linkage success rate, provides a comprehensive longitudinal picture of key health outcomes. So now we'll focus more on the cancer incidence branch of this research program, and I'll present findings from our initial CFCAMS cancer incidence study, which we presented at CIMVHR Forum last year. The objectives were twofold. The first was to describe the rate of overall primary cancer, as well as rates for specific cancer types among male and female Canadian Armed Forces personnel and veterans. The second was to compare these rates to the general population, and we conducted these comparisons for our overall population of military personnel and veterans, as well as subgroups, which were defined by service characteristics. So the study population for this initial study, it included all regular force and reserve force C personnel who first enrolled between 1976 to 2016. This resulted in just over 210,000 males and just under 35,000 females. While the study design allowed for up to 42 years of follow-up, the mean follow-up time at the individual level was 22 years. By the end of follow-up, which was in 2017, or at the time of mortality, whichever came first, approximately 70% of our study sample had released and were veterans. For age, approximately 60% of our study sample by the end of follow-up were between the ages of 40 to 59. And only 8% of the study population was 60 years of age or older. This relatively young age distribution of this study population is important to keep in mind for interpretation of the findings, as the risk of many cancers increases with age. For service years, while 40% of the study population had 10 or more years of service, approximately 25% had less than 2. For the outcomes, we measured overall cancer as well as specific cancer types, which was identified using primary incident cancer diagnoses occurring in our study population from 1976 to 2017. We calculated crude incidence rates, and we used indirect standardization methods to compute standardized incidence ratios, also known as SIRs for short. The standardized incidence ratio represents the ratio of cancer cases that we actually observed in our study population divided by the number of cancer cases that we would expect to observe if our study population experienced cancer at the exact same rate as the Canadian general population. As you can see in the figure, if the SIR is less than 1, that means that our study population has a lower rate of the indicated cancer than the Canadian general population. Likewise, if the SIR is greater than 1, that indicates that our study population has a higher rate of the indicated cancer than the Canadian general population. For this study, standardized incidence ratios were calculated for males and females separately at the level of the 5-year age group and individual calendar year. So in this way, the study methods account for potential differences in sex, age, and calendar year between our study population and the general population. We also performed additional stratifications by service characteristics. This slide includes the crude rates for male personnel and veterans. We have male personnel in blue and male veterans in gold. The most common cancers observed for male personnel were cancers of the testes, melanoma, and prostate cancer. For male veterans in green, the most common cancers were prostate, colorectal, and lung and bronchus cancer. This is a similar slide, but for females. Note that this does include some female-specific cancers. For female personnel in blue, the most common cancers were breast, followed by thyroid cancer and melanoma. Whereas for female veterans in gold, the most common cancers were breast cancer, followed by lung and bronchus and colorectal cancer. Here we compare these rates of cancer to the Canadian general population. All estimates account for sex, age, and calendar year. We have males on the left in dark gray and females on the right in green. The asterisks indicate where statistically significant differences were observed. All cancers is included in the top row of the figure. For both males and females in our study population of Canadian Armed Forces personnel and veterans, we observed significantly lower rates of all cancer compared to their Canadian general population counterparts after accounting for age and calendar year. For males, and to a lesser extent females, we also observed significantly lower rates of several other cancer types. There was only one cancer type that was elevated in our study population of personnel and veterans, and this was melanoma, and this finding for melanoma was observed in both males and females. We also conducted subgroup analyses. Subgroups were defined by service characteristics, including service status, so whether they were serving personnel or a veteran, service rank, as well as whether or not they had a history of international deployment or posting. We only conducted stratifications by one service variable at a time. So the subgroups by rank and deployment include both personnel and veterans. Again, all estimates on this slide account for differences in sex, age group, and calendar year that might potentially exist between these subgroups and the general population. For the subgroup analyses, for most subgroups and most cancer types, we observed either lower or similar rates in comparison to the Canadian general population, similar to the previous slide. However, for some combinations of subgroups and cancer type, we did observe some elevated rates, and these are summarized here on this slide. I won't read out all of the results, but as an example, among both male and female personnel, officers, and people who had a history of international deployment or posting, as well as males who were senior non-commissioned members, we observed an elevated rate of melanoma compared to the Canadian general population. While we did control for age and sex in these analyses, we did not control for other variables, many of which were not available in our administrative data. So for example, we were unable to control for ethnicity, which may be relevant to the findings for melanoma, as persons of Caucasian ethnicity have historically been overrepresented in the CAF, and Caucasian ethnicity is also a risk factor for melanoma. We also weren't able to control for health behaviors such as smoking, which may be relevant to our findings for lung and bronchus cancer. For example, are the elevated rates of lung and bronchus cancer among junior non-commissioned members, are these due to a higher prevalence of smoking in this subgroup compared to the Canadian general population? Or is it due to the hands-on nature of some junior non-commissioned members' jobs, which may potentially involve handling chemicals or other hazardous exposures? Answers to questions such as this, raised by these findings, offer important implications for cancer prevention, screening, and benefits in CAF personnel and veterans. So, how are we applying these results? At the Department of National Defense, results from our initial cancer incident study have informed a review of sun protection policies and practices in the Canadian Armed Forces. In particular, a senior medical officer, who is both a dermatologist and skin oncologist, is working together with the Force's health promotion team called Strengthening the Forces. Together, they will review if additional information on skin cancer risk for Canadian Armed Forces personnel is warranted beyond that which already exists. At Veterans Affairs Canada, our knowledge translation efforts so far have focused on sharing these results with health practitioners and decision makers to support and inform their work. For example, this type of evidence can be useful for decision makers tasked with assessing the service relatedness of diagnoses associated with claims for cancer benefits. The results are also important to inform new research questions, such as further investigation into potential risk and protective factors in Canadian Armed Forces personnel and veterans. The work also has implications beyond the Canadian context. We have met and reviewed and discussed our methods and approach with our colleagues from the United Kingdom and the United States, who are looking into developing similar programs and data linkages. International collaboration offers great opportunity to leverage existing knowledge and work collectively towards identifying and addressing health risks and burden. So where is this research headed? At Veterans Affairs Canada, in the last year, we have continued our analyses of cancer incidence using the CFCAMS database. Our more recent analyses have had a focus in females, including the identification of age and time-based trends in cancer incidence. We also recently conducted analyses examining associations between service within specific military occupations and long-term likelihood of subsequent development of cancer. Another potential avenue for future analysis is to examine the participation in specific international operations, such as the Persian Gulf War and the Afghan conflict. I have to say, we are excited about the upcoming CFCAMS data linkage, as this will provide additional information to investigate health trends, particularly as this relatively young cohort enters older age. At Veterans Affairs Canada, we are also undertaken additional activities to understand cancer incidence in Canadian Armed Forces personnel and veterans. This includes an analysis of claims to Veterans Affairs Canada for cancer-related benefits, as well as a review on the links between military occupational exposures and cancer in women. This latter study was funded through the Joint Federal Funding Research Program. These are the photo credits for the photos used throughout the presentation. And before we wrap up, I want to leave you with one last question for thought. As I hope has been evident throughout this presentation, data linkage methodologies have vastly improved our ability to identify health outcomes within and across populations. However, a common issue across the fields of occupational epidemiology and occupational health is a lack of high-quality, individual-level exposure data. Questions about who is exposed and how much, and what are the impacts of these exposures can be answered through proper planning, data collection, investment, data integration, centralization, as well as research to leverage this data to its full potential. I think it's also useful to think about this question prospectively. So thinking about the military missions and duties of today, as well as even tomorrow upcoming, what sort of exposures might be present that may be of concern for policy and research in the future? And what data should we be collecting today in preparation? So with that, thank you very much for your attention. My email is here on the slide for anyone wishing to follow up about the presentation, and the URL you can use to read about a brief synopsis of our initial study. Thank you.